Foundations of Maternal-Newborn and Women's Health Nursing by Murray, McKinney, Holub, and Jones. 7th edition. Chapter 14. Intrapartum Fetal Surveillance. The primary goal of intrapartum fetal surveillance is to enable clinicians to assess adequacy of fetal oxygenation during labor. Over several decades, the principal method of intrapartum monitoring of fetal well-being and uterine activity, UA, has transitioned primarily from low-technology auscultation and palpation to high-technology electronic fetal monitoring, EFM. Approximately 89% of births in the United States are monitored electronically, whereas exclusive use of auscultation and palpation in the intrapartum setting is limited. The low-technology method of fetal surveillance requires a clinician to count the fetal heart rate, FHR, with a fetoscope or Doppler in relation to UA. Counting and palpation occur at specified intervals for a predetermined amount of time depending on the stage of labor and patient risk status. Palpation of the uterus by the clinician provides UA information such as frequency, duration, intensity, and resting tone. Unlike auscultation and palpation, EFM incorporates a complex electronic device that acquires, processes, and displays the FHR and UA with visual and computer interpretation. This device may provide additional information compared with intermittent auscultation, IA, in identifying fetuses at risk for hypoxic injury that may result in permanent neurologic injury or death. Each method of fetal surveillance has advantages and limitations. Both approaches can be interchanged depending on pregnancy risk factors, current clinical situation, patient's preference, nurse-to-patient ratio, and institutional policy. When necessary, timely and appropriate corrective measures can be taken to improve fetal oxygenation and avoid unnecessary interventions. Regardless of which method is used for surveillance, information gathered at the bedside during the intrapartum period can assist clinicians with the following. 1. Evaluating fetal oxygenation based on bedside assessments and accurate interpretation of data. 2. Deciding when implementation of physiologically based corrective measures to improve fetal oxygenation is necessary. 3. Providing a continuing mechanism to optimize communication between clinicians and patients. 4. Supporting clinical decision-making, which promotes an environment that improves patient safety and healthcare quality. Fetal oxygenation. The placenta, which contains both maternal and fetal tissue, functions as an extracorporeal fetal support system. In other words, the placenta is responsible for gas, nutrient, and substance exchange for fetal growth, development, and oxygenation. The placenta also plays a vital role in metabolism, endocrine secretion, immunologic safeguards, and protection of the fetus against certain substances in maternal circulation that may be harmful, such as some viruses and medications. An understanding of the dynamics of utero-placental exchange and maternal-fetal circulation is essential to understanding how fetuses respond to labor stressors such as uterine contractions. As mentioned in Chapter 9, oxygen is carried from the environment to the fetus by a maternal and fetal circulation pathway that includes maternal lungs, heart, vasculature, uterus, placenta, and umbilical cord. Adequate fetal oxygenation requires the following. 1. Sufficient maternal blood flow and volume to the placenta. 2. Normal maternal oxygen saturation. 3. Adequate placental exchange of oxygen and carbon dioxide. 4. An open circulatory path from placenta to fetus through umbilical cord vessels. 5. Normal fetal circulatory and oxygen-carrying functions. Interruption of the oxygen pathway at one or more points can cause physiologic changes resulting in characteristic FHR changes that may be interpreted on the tracing. Uroplacental circulation. Maternal blood flow to the uterus and placenta originates primarily in the uterine, internal, iliac, and ovarian arteries. Approximately 85% of uterine blood flow supplies volume for utero-placental circulation, and the remaining percentage circulates blood to uterine musculature. Maternal arterial blood pressure maintains flow of oxygen and nutrient-rich blood to the uterus, placenta, and finally to the intervillous spaces of the placenta via spiral arteries. In the non-pregnant state, spiral arteries are small vessels supplying blood to the uterine endometrium. In the first few weeks of pregnancy, spiral arteries are remodeled to meet the growing demands of the developing fetus. The fetal chorionic villi, which are protrusions of fetal tissue, are located in the intervillous spaces of the placenta, where the microscopic branches of the chorionic villi are immersed in maternal blood for the remodeled spiral arteries. The intervillous space allows for exchange of substances such as oxygen without mixing of maternal and fetal blood. Figure 14.1. Simultaneously, maternal blood carrying away carbon dioxide and fetal waste products drains from the intervillous spaces through endometrial veins and returns to maternal circulation for elimination. Spiral arterial blood flow can be altered by maternal cardiac output and impact the blood flow to the placenta and fetus. For example, when the uterus contracts, elevated myometrial pressure at the peak of a contraction can exceed intra-arterial pressure within the spiral arteries. This causes a temporary cessation of maternal blood flow to the intervillous space. If this interruption is prolonged, acute or chronic episodes of hypoxia can occur. Dramatic changes in maternal blood pressure can affect blood flow in the intervillous space. The fetus responds to these interruptions by redistributing blood flow to the vital organs, heart, brain, and adrenal glands, and decreasing blood flow to the non-vital organs, lungs, kidneys, liver, gastrointestinal tract, and periphery. Persistent redistribution of blood flow may cause a loss of fetal cerebral autoregulation, resulting in decreased fetal cardiac output. If this physiologic process continues, a reduction of cerebral blood flow could potentially result in fetal neurologic injury or death. Fetal placental circulation. The umbilical cord connects the placenta to the fetus. Within the umbilical cord are 3 vessels, 2 arteries, and 1 vein, which is protected by Horton's jelly. Oxygenated blood is carried to the fetal heart from the placenta via placental veins that form a single umbilical vein. The fetal heart then circulates oxygenated blood throughout the fetal body. After the blood has circulated, 2 umbilical arteries return to the placenta, then separate into smaller vessels at the umbilical cord insertion site on the placenta. See figure 5.7. An arteriovenous system is created within the chorionic villi, allowing for deoxygenated blood from the fetus to be returned. Fetal heart rate regulation. In the fetal medulla oblongata, a cardioregulatory center acts as the source of FHR regulation via the following. 1. Intrinsic cardiac pacemakers, sinoatrial node, arterioventricular node. 2. Cardiac conduction pathways. 3. Sympathetic and parasympathetic branches of the autonomic nervous system. 4. Intrinsic factors such as baroreceptors and chemoreceptors. 5. Extrinsic factors such as maternal medications or placental abruption. 6. Hormonal influences. 7. Miscellaneous factors, calcium, potassium. Changes in fetal oxygen and carbon dioxide, chemoreceptors, or blood pressure, baroreceptors, affect the cardioregulatory center controlling the FHR baseline, variability, accelerations, and decelerations. For example, if the cardioregulatory center detects hypoxia, it signals the heart to alter the cardiac output and redistribute blood flow primarily to the vital organs, such as the brain, heart, and adrenal glands. Thus, The fetal heart rate patterns represent the final product of intrinsic and extrinsic factors. Autonomic nervous system. The autonomic nervous system, ANS, is a neural network that assists with maintaining physiologic stability in such areas as the cardiovascular system, when challenged by circumstances that can interrupt normal function. This is also referred to as homeostasis. The ANS is divided into the parasympathetic and sympathetic branches and are the balanced forces regulating the FHR. The parasympathetic branch is an important mechanism in controlling the heart. Parasympathetic impulses originate in the fetal brainstem and are distributed to the vagus nerve and heart. When the vagus nerve is stimulated, the parasympathetic branch decreases the baseline rate over time. Sympathetic impulses originate in the fetal myocardium and increase the FHR baseline. The sympathetic system also can stimulate the release of catecholamines in response to interruptions in oxygenation and blood pressure changes. This results in an increased FHR and possible peripheral vasoconstriction in the fetus. Fetal heart rate variability is a component of the baseline and reflects changes in variance over time between consecutive heartbeats. It is a direct result from the sympathetic and parasympathetic effects on the heart, similar to a push and pull method. This FHR characteristic originates in the brainstem and is conducted to the fetal heart by the vagus nerve. Variability is considered the most critical predictor of adequate fetal oxygenation during labor for the following two reasons. 1. Adequate oxygenation promotes normal function of the ANS and helps the fetus maintain homeostasis during labor. 2. Variability evaluates the function of the fetal ANS. Baroreceptors and chemoreceptors. Located in the carotid arch and aortic sinus, baroreceptors are pressure-sensitive stretch receptors that respond to blood pressure changes. Baroreceptors perceive blood pressure alterations and send a signal to the brainstem. This results in either slowing of the FHR to decrease blood pressure or increases the FHR to resolve hypotension in the fetus. Receptors are located in the medulla oblongata as well as the aortic and carotid bodies. They are less understood but are thought to be sensory nerve endings that are stimulated by alterations in oxygen, carbon dioxide, and fetal blood pH. Chemoreceptors respond to blood pH and oxygen decreases or increases in carbon dioxide by eliciting a sympathetic response. This response increases FHR to improve oxygenation or decrease carbon dioxide. Hormonal influences. Hormones are circulated into the bloodstream by organs such as the adrenal glands, hypothalamus, and pituitary gland. Stressors such as too many contractions trigger the fetus to release hormones that will assist the FHR regulation, maximizing perfusion to the vital organs. The adrenal medulla secretes catecholamines, epinephrine and norepinephrine. Epinephrine and norepinephrine increase myocardial contraction force, accelerate the FHR, and improve arterial blood pressure, equal to sympathetic branch stimulation. Decreases in fetal blood pressure cause the adrenal cortex to respond by release of aldosterone and retention of sodium and water, which will increase circulating fetal blood volume. Electronic fetal monitoring instrumentation. Intermittent auscultation, IA, of the FHR and palpation of UA were the only methods of fetal assessment until the introduction of EFM in the late 1960s. By the late 1970s, EFM was estimated to be used in over half of U.S. births. While IA and palpation continue to be a reasonable approach to assessing fetal status in a low-risk patient, EFM technology gained popularity. Compared with earlier generations of fetal monitoring systems, today's EFM systems are more innovative than previous systems, allowing for more efficient bedside care. Intermittent auscultation and palpation. IA, in conjunction with palpation, has been found to be an effective method of surveillance if performed in a consistent manner in accordance with professional guidelines. This method of assessing FHR and rhythm is done with a fetoscope, Pinard stethoscope, or handheld Doppler ultrasound. Unlike Doppler ultrasound, which translates fetal heart motion into a signal, a fetoscope or Pinard stethoscope allows the listener to hear actual fetal heart sounds, which include opening and closing of fetal heart valves. In most facilities, the Doppler is selected to auscultate the FHR intermittently. There's a lack of evidence of which method of IA and intervals of counting are best for laboring women. One example of determining FHR baseline describes clinicians listening and counting for a set period, usually 15 to 60 seconds. Longer periods of counting may be required depending on the clinical situation. For example, if the FHR is within normal limits but has changed significantly from the previous assessment, a longer listening period or more frequent assessments may clarify whether the rate is a change in baseline or a temporary increase or decrease. Counting is done between contractions and when the fetus is not actively moving. Clinicians should palpate a maternal radial pulse simultaneously to distinguish between maternal heart rate and FHR during auscultation. Rhythm should be noted as regular or irregular. The FHR is auscultated at selected intervals based on the woman's risk status and institutional guidelines. Audible increases or decreases may be detected once a baseline rate has been established. During episodes or audible changes, counting in consecutive 6-second intervals and multiplying the rate by 10 should give the clinician an estimate in the beats per minute, BPM, during increases or decreases. Another IA method includes FHR counting in several 5 to 15 second increments. An increase in the number obtained from each 5 or 15 second count can indicate an acceleration, whereas a decrease in the rate can suggest a deceleration. An abrupt decrease in rate from the baseline should be followed with other measures to clarify the fetal condition, such as continued assessment or placement of an EFM device. Palpation is a subjective method of assessing UA. The uterus is a muscle, and as the uterus contracts, the muscle gradually becomes firm. After the contraction is over, the muscle relaxes and becomes soft. Palpation with the fingertips allows for assessment of UA frequency, duration, intensity, resting tone, and relaxation time. Because palpation is subjective, descriptive terms such as mild, moderate, and strong, or firm are used for UA. If a uterine contraction is easily indented, it is described as mild. Some clinicians suggest that a mild contraction feels similar to the tip of the nose. Slight indentation of the uterus is described as a moderate contraction, which feels equivalent to the chin. Strong contractions result in a uterus that cannot be indented and palpates similar to the forehead. Benefits of auscultation and palpation. Benefits of auscultation and palpation are as follows. Widely available and easy to use with proper training. Less invasive than EFM. Outcomes comparable to those with EFM in low-risk women. Inexpensive. Promotes an atmosphere for the laboring patient that is more natural than one primarily dependent on technology. Comfortable for the woman. Offers women freedom of movement and ability to ambulate to promote normal labor. One-on-one nursing care promotes doula effect benefits. Allows easy FHR and UA assessment during use of hydrotherapy. Limitations of auscultation and palpation. The limitations of auscultation and palpation are as follows. Difficult to perform in some situations, such as hydramnios and maternal obesity. Patient may be intolerant of clinician's touch during contraction. Does not provide a permanent, documented visual record of the FHR or UA. Counting of FHR is intermittent. cannot assess visual patterns of FHR variability or periodic and non-periodic changes. Unable to determine UA intensity objectively. Significant events such as prolonged decelerations may occur during periods when the FHR is not auscultated. May not allow early detection of FHR changes reflective of hypoxemia. Not recommended for high-risk pregnancies. Bedside fetal monitor and transducers. Instrumentation used for EFM include a bedside fetal monitoring unit and transducers with cables to capture data, figure 14.3. Fetal monitoring units collect FHR and UA information to provide a visual output in the form of a numerical display and a graphic strip, figure 14.4. Some monitors can simultaneously record twin and triplet heart rates. Current systems have inputs to collect maternal data, including temperature, oxygen saturation, electrocardiographic status, and blood pressure. In addition to the bedside, display units may be at the nursing station or other locations to allow remote surveillance when the clinician is not at the bedside. These units display the tracing on a screen and have settings for audible and visual alerts such as upper and lower limits for maternal vital signs and FHR baseline. Modern labor and delivery units may have wireless monitoring systems that transmit data to a base station for interpretation. Wireless systems allow patients the opportunity to ambulate in labor and can be used in water. External FHR is obtained by Doppler, also known as ultrasound, and UA is acquired by a tokodynamometer, TOCO. External monitoring, also called indirect or non-invasive monitoring, can be used at any time because cervical dilation and ruptured membranes are not necessary for placement. Devices are held in place with either an elastic belt or adhesive patch that attaches to the transducer. Recording FHR requires ultrasound conduction gel to be applied on the Doppler surface. This gel assists in transmission of high-frequency sound waves to the level of the fetal heart where heart motion is detected. Waves then bounce back to be recorded by the bedside unit. After confirming the location of the fetal back with Leopold's maneuver, the ultrasound transducer is placed where the point of maximum intensity of the FHR can be heard. Procedure 14.2. A TOCO is required to detect UA and is usually placed at the level of the fundus or where contraction intensity is palpable. Figure 14.5. Those do not require ultrasound conduction gel because a pressure-sensitive button identifies change in uterine shape occurring with contractions or maternal fetal movement. Benefits of ultrasound and tokodynamometer transducers. The benefits of ultrasound and tokodynamometer transducers are as follows. Non-invasive, easy to apply, may be used during both the antepartum and intrapartum periods, sometimes used with telemetry when available, does not require ruptured membranes or cervical dilation, no known risks to woman or fetus, provides continuous recording of the FHR and UA. Limitations of ultrasound and tokodynamometer transducers. The limitations of ultrasound and tokodynamometer transducers are as follows. Limit maternal mobility. Frequent repositioning of transducers often needed to maintain readable, accurate tracing. May double count a slow FHR of less than 60 bpm, resulting in an apparently normal FHR during a bradycardia, or may half count a FHR greater than 180 bpm, resulting in an apparently normal FHR during tachycardia. Maternal heart rate may be recorded if ultrasound transducer is placed over maternal arterial vessels, such as the aorta. TOCO transducer provides information limited to frequency, duration, and relaxation time of uterine contractions, but cannot accurately assess strength or intensity of uterine contractions. Obese women and preterm or multifetal gestations may be difficult to monitor. Fetal monitoring requires a fetal spiral electrode (FSE) to record FHR and an intrauterine pressure catheter (IUPC) to document UA. Internal monitoring is referred to as direct or invasive fetal monitoring because this method requires cervical dilatation, usually 2 centimeters, and ruptured membranes. Electrodes are applied directly to the fetal presenting part, head or buttocks, and never placed on the fetal genitalia, face, or fontanelles. Each electrode measures, processes, and records the R to R interval in a QRS complex to record the FHR. The opposite end of the electrode is attached to a pad and secured on a woman's thigh or lower abdomen. The cable is attached to the pad and plugged into the fetal monitor, figure 14.6. Electrodes should not be placed if there is an unidentifiable presenting part, placenta previa, hemophilia, maternal human immunodeficiency virus infection, visible genital herpes lesions, or patient report of prodromal lesions symptoms. In cases of extreme prematurity or in the presence of a maternal infection such as hepatitis, group B hemolytic streptococcus infection, syphilis, or gonorrhea, electrode placement may be acceptable if fetal benefit outweighs risk. When a tracing warrants better assessment of frequency, duration, intensity, resting tone, and relaxation time, an IUPC may be inserted into the uterus transcervically. This sterile, flexible catheter measures actual intrauterine pressure, figure 14.7. Presently, there are 3 IUPC types: fluid-filled, transducer-tipped, and air-coupled sensor-tipped. Data are transmitted by an electrical signal that converts uterine pressure data into millimeters of mercury, mmHg. This pressure is then displayed on the fetal monitor. Benefits of fetal spiral electrodes. The benefits of FSEs are as follows: capable of accurately displaying some fetal cardiac arrhythmias when linked to electrocardiographic recorder. Accurately displays an FHR between 30 and 240 BPM. Maternal positional changes do not usually affect quality of FHR tracing. Benefits of intrauterine pressure catheters. The benefits of IUPCs are as follows: only truly accurate measure of all UA, e.g. frequency, duration, intensity, resting tone, and relaxation time. Allows for use of amnio infusion. Limitations of fetal spiral electrodes. The limitations of FSEs are as follows: requires ruptured membranes. Cervix must be dilated sufficiently to allow placement. Improper insertion can cause maternal trauma, such as vaginal lacerations. Presenting part must be accessible and identifiable. May record maternal heart rate in presence of fetal demise. May not have adequate electrographic conduction when excessive fetal hair is present. Possible increased risk for infection. Limitations of intrauterine pressure catheters. The limitations of IUPCs are as follows: requires ruptured membranes. Cervix must be dilated sufficiently to allow placement. Improper insertion can cause maternal or placental trauma, such as uterine perforation or placental abruption. Maternal positioning may change uterine hydrostatic pressure, resulting in inaccurate findings. Different IUPC types may give higher pressure readings than other types. Possible increased risk for infection. Fetal monitoring tracing. Fetal monitors capture FHR and UA data, which prints on a continuous paper tracing similar to an electrocardiogram strip. Some institutions prefer data be recorded on a computer tracing that is viewed at the bedside or a remote location instead of paper. Regardless of the mode, each tracing has an x-axis and y-axis with an upper and lower graph, figure 14.8. FHR information is traced on the upper graph and UA is recorded on the lower graph. The x-axis on the upper and lower graph reveals thin, light vertical lines that represent 10-second intervals. Every 60 seconds, a thick, dark vertical line is printed representing 1-minute intervals. The y-axis also has thin, light horizontal lines, with the upper graph recording FHR in intervals of 10 BPM ranging from 30 to 240 BPM. The y-axis on lower graph records uterine pressure in increments of 5 mm mercury ranging from 0 to 100 mm mercury. Fetal heart rate interpretation. Fetal monitoring was launched into daily clinical practice without a nationally agreed upon consensus statement regarding FHR patterns and definitions. Clinicians had broad variations in definitions, descriptions, and interpretations of FHR characteristics to communicate findings. For example, a clinician may have described tachysystole, increased uterine activity, as greater than 5 contractions in 10 minutes, as another may have described tachysystole as 5 or more contractions in 10 minutes. The lack of standardization was a key obstacle in effective communication and had the potential to lead to adverse perinatal and neonatal outcomes. The first consensus statement standardizing definitions was released by the National Institute of Child Health and Development, NICHD, but was slow to be integrated into intrapartum care. In 2006, professional nursing and physician organizations endorsed the document. In 2008, a panel of experts reaffirmed the 1997 document and added UA definitions and categories of FHR tracings. During the intrapartum period, clinicians need to understand and acknowledge 3 fundamental concepts to using a systematic approach to fetal monitoring. 1. Standardized definitions, or nomenclature, that is used to define FHR and UA characteristics. 2. Interpretation, or the physiologic significance of the FHR and UA characteristics. And 3. Management, or the clinical response to FHR and UA characteristics. Baseline fetal heart rate. Baseline FHR is determined by approximating the mean FHR rounded in 5 BPM increments during a 10-minute period. In this 10-minute assessment, periodic and episodic changes, accelerations and decelerations, and periods of marked variability are excluded. During the 10-minute period of observation, there must be at least 2 minutes of identifiable baseline segments that do not need to be contiguous. If a 2-minute period is uninterpretable, the FHR baseline is considered indeterminate. The previous 10-minute period may need to be reviewed to establish a baseline. Baseline rates are classified as follows. Normal FHR baseline, 110 to 160 BPM. Preterm fetuses often average a rate at the upper end of normal because the sympathetic branch of the ANS is more dominant. These fetuses may have a baseline rate at the lower end of normal. Abnormal baseline FHR, tachycardia, greater than 160 BPM. Physiologically, increases in sympathetic or decreased parasympathetic tone cause tachycardia. Potential causes of FHR tachycardia are presented in box 14.1. Bradycardia, less than 110 BPM. Physiologically, increases in parasympathetic and decreases in sympathetic tone cause bradycardia. The potential causes of FHR bradycardia are presented in box 14.2. Baseline fetal heart rate variability. Baseline FHR variability is determined in a 10-minute window, excluding periodic and episodic changes. Variability is defined as fluctuations in the baseline FHR that are irregular in amplitude and frequency. These fluctuations are visually quantitated as the amplitude of the peak to trough in beats per minute. Variability is classified as follows. Figure 14.9. Absent variability, amplitude range visually undetectable. Minimal variability, amplitude range visually detectable, but 5 bpm or less. Moderate variability, amplitude range 6 bpm to 25 bpm. Marked variability, amplitude range 25 bpm or greater. Moderate variability reliably predicts the absence of fetal metabolic acidemia at the time it is observed. However, the opposite is not true. Minimal or absent variability does not confirm the presence of fetal metabolic acidemia or ongoing hypoxic injury. Because there may be other pathologic and non-pathologic causes, such as fetal sleep, box 14.3. Marked variability is considered a normal variant or an exaggerated ANS response to the early phase of interrupted fetal oxygenation. Sinusoidal patterns are excluded from the definition of variability because this pattern is characterized by FHR fluctuations that are regular in amplitude and frequency. This pattern appears as a visually apparent, smooth, sine wave-like undulating pattern in the FHR baseline with a cycle frequency of 3 to 5 per minute that persists for 20 minutes or more. The pattern may be intermittent or continuous. Accelerations and responses to UA, fetal movement, or stimulation are absent. True sinusoidal patterns are extremely rare and have been associated with severe fetal anemia as a result of conditions such as RH alloimmunization, vasoprevia, or twin-to-twin transfusion. In the past, the term pseudosinusoidal has been used to describe a sinusoidal appearing pattern after medication administration. This term is not defined in standardized EFM definitions. Common medications associated with this pattern include fentanyl, butorphanol, and meperidine. Sinusoidal patterns that are medication-induced are short-lived and followed by a FHR with normal characteristics. Clinicians must have the ability to differentiate between a true sinusoidal pattern and one that is related to medication administration. True sinusoidal patterns suggest a compromised fetus, so a bedside evaluation is necessary to optimize perinatal outcome. Periodic and episodic fetal heart rate patterns. Periodic FHR patterns are those associated with uterine contractions. Periodic patterns are distinguished on the basis of waveform and are either abrupt or gradual in onset. Abrupt waveforms are quantified as those that have an onset to nadir, lowest point, of deceleration or peak of acceleration in less than 30 seconds. Gradual waveform takes more than 30 seconds. Episodic, non-periodic patterns may have an abrupt or gradual onset but are not linked with UA. Accelerations. Accelerations are defined as visually apparent, abrupt increases in the FHR and may be periodic or non-periodic. The peak of the acceleration must be at least 15 bpm above the baseline, lasting at least 15 seconds or more from the onset to return, figure 14.10. The onset to peak occurs in less than 30 seconds. In gestations that are less than 32 weeks, the peak of the acceleration must be at least 10 bpm above the baseline, lasting at least 10 seconds from onset to return. Prolonged accelerations have a duration between 2 and 10 minutes. Anything greater than 10 minutes is considered a FHR baseline change. Accelerations often occur with fetal movement, but also may be elicited with vibroacoustic stimulation, uterine contractions, or fetal scalp stimulation during a vaginal examination. Scalp stimulation is used to evaluate fetal response to gentle tactile stimulation through a dilated cervix when an indeterminate FHR tracing is observed. Scalp stimulation should not be attempted during a deceleration. The goal is to elicit an FHR acceleration, suggesting normal acid-base balance. Accelerations, whether spontaneous or evoked, are predictive of adequate oxygenation and a fetal pH that rules out acidemia, 7.19 or greater, at the time of observation. Early decelerations. Early decelerations are defined as periodic patterns that are visually apparent, are symmetric in shape, and have a gradual decrease and return of FHR baseline that mirrors a uterine contraction. This means the deceleration onset, nadir, and recovery coincides with the beginning, peak, and ending of a contraction. The onset of the deceleration to the nadir is equal to or greater than 30 seconds. Early decelerations are thought to represent a vagal response during fetal head compression. This response alters intracranial blood flow and leads to cardiac slowing. Early decelerations are benign and not associated with an interruption of fetal oxygenation resulting in fetal hypoxia, acidosis, or low APGAR scores. Late decelerations. Late decelerations are also considered a periodic pattern. They are visually apparent and usually symmetric in shape, with a gradual decrease and return of the FHR baseline. Late decelerations occur when the onset of the deceleration to the nadir is equal to or greater than 30 seconds, and the nadir of the deceleration occurs after the peak of the contraction. Decelerations are thought to occur with decreased blood flow through the intervillous space, resulting in fetal hypoxia. In most cases, late decelerations appear before the loss of variability, i.e., moderate to minimal, and are a reflex to transient fetal hypoxia caused by an interruption anywhere along the oxygen pathway, such as maternal hypotension. Once corrective measures such as maternal lateral positioning are initiated, these decelerations will typically dissipate. Late decelerations become more concerning when they are recurrent, present with 50% or more of the uterine contractions in a 20-minute period, and associated with tachycardia and a loss of variability. If uncorrected, hypoxic stress will lead to an accumulation of oxygen debt. Deoxygenated blood will be insufficient for myocardial metabolism, which can be linked to acidemia and neonatal depression. Variable decelerations. Variable decelerations may be either periodic or episodic patterns. These decelerations are visually apparent, abrupt decreases from onset to nadir of a deceleration. The onset of the deceleration to the nadir is less than 30 seconds. The decrease is at least 15 bpm below the baseline, with the deceleration lasting at least 15 seconds and no longer than 2 minutes from the onset to the return to baseline. Deceleration shape, depth, duration, and timing in relationship to contractions may vary. Variable decelerations are the most frequent type of deceleration during first and second stage labor. Variable decelerations are suggestive of an interruption of oxygenation at the level of the umbilical cord, where cord vessels may be compressed. Physiologically, the thin-walled umbilical vein is occluded during umbilical cord compression in situations such as umbilical cord prolapse or olighydramnios. Fetal venous response is decreased, and baroreceptors trigger a rise in FHR that sometimes appears as a shoulder before deceleration onset. As the umbilical cord continues to be occluded, the compressed umbilical arteries cause an abrupt increase in fetal peripheral resistance and blood pressure. Baroreceptors detect the abrupt rise in blood pressure and signal the brainstem to increase parasympathetic outflow, results in an abrupt FHR decrease. Once the umbilical cord is decompressed, umbilical arteries open and an increase in the FHR occurs. Once all the umbilical cord vessels are open, the FHR usually returns to the previous baseline. Generally, variable decelerations are not associated with significant hypoxia or acidosis as long as they are intermittent and accompanied by normal baseline rate and variability. If cord compression is recurrent or prolonged, interruption in fetal oxygenation can progress to hypoxemia, hypoxia, metabolic acidosis, and metabolic acidemia if corrective measures are not successful. Regardless of whether variable decelerations are intermittent or recurrent, they should be evaluated and managed appropriately. Prolonged decelerations. Similar to variable decelerations, prolonged decelerations are either periodic or episodic and are generally isolated on the tracing. These decelerations are defined as a decrease in the FHR that lasts a minimum of 2 minutes and no longer than 10 minutes from onset to return to baseline. Figure 14.5. After 10 minutes, the deceleration is considered a baseline change. From a physiologic standpoint, prolonged decelerations are difficult to classify. Some experts think the same mechanisms responsible for late or variable decelerations are responsible for FHR changes associated with prolonged deceleration, only they last longer. Regardless, a prolonged deceleration reflects interruption of oxygen transfer from the environment to the fetus at one or more points along the oxygen pathway. Standardized definitions are used to describe UA, which is quantified as the number of contractions in a 10-minute window of time, averaged over 30 minutes. Calculated from onset of one contraction to onset of next contraction, described in minutes. Duration, calculated from onset of one contraction to end of the contraction, described in seconds. Intensity, strength of contraction peak. When palpation or a toco is used, intensity is described as mild, moderate, or strong, firm. Quantitative numbers in the form of millimeters of mercury are used with an IUPC. Resting tone, amount of intrauterine tone when the uterus is at rest, described as soft or relaxed when normal and firm, or not relaxed when abnormal, with palpation or millimeters of mercury with an IUPC. Normal resting tone is approximately 10 millimeters of mercury with an IUPC, and hypertonus is greater than 20 to 25 milligrams mercury with an IUPC. Relaxation time, calculated as the amount of time from the end of one contraction to the beginning of next contraction, described in seconds. A systemic approach to these criteria should always be used when assessing UA. Once assessment is complete, the following terminology is used to describe UA. Normal, 5 or fewer contractions in 10 minutes, averaged over a 30-minute period. Tachysystole, more than 5 contractions in 10 minutes, averaged over a 30-minute period, regardless of whether periodic or episodic changes of the FHR are present. Terminology such as hyperstimulation or hypercontractility is no longer accepted. Montevideo units, MVUs, sometimes may be used to describe contraction intensity over a 10-minute period when an IUPC is in place. The MVU is calculated by noting each contraction's intensity in millimeters of mercury and subtracting the resting tone. Numbers are added together to report MVUs during that time frame. For example, if a woman has 4 contractions in 10 minutes, with an intensity of 70, 60, 70, and 80 millimeters of mercury, and a uterine resting tone of 10 millimeters of mercury, this will be calculated as 70 minus 10 plus 60 minus 10 plus 70 minus 10 plus 80 minus 10, which results in a total of 240 MVUs during that 10-minute period. Categorization of fetal heart rate patterns. Over time, certain FHR characteristics have been predictive of neonatal outcome. This continuum starts with FHR characteristics considered normal for an oxygenated fetus. Over time, when interruptions in oxygenation occur, the continuum moves from normal to indeterminate patterns that suggest hypoxemia or hypoxia. Finally, if uncorrected, these indeterminate patterns may evolve to abnormal patterns that are predictive of inadequate tissue oxygenation, leading to metabolic acidemia. A three-tiered categorization system has been suggested for use during the intrapartum period. Using a three-tiered category system provides a meaningful way to communicate with other clinicians. This system is also a reasonable alternative to using vague, ill-defined terms such as reassuring or non-reassuring. Categories of FHR interpretation include the following. Category 1. Normal and are strongly predictive of normal fetal acid-base status at the time of observation. Category 2. Indeterminate and fetal acid-base status is uncertain. Category 3. FHR abnormal and predictive of abnormal fetal acid status at the time of observation. Patterns associated with each category are presented in box 14.4.